axilla of a woman who had hidradenitis suppurativa, which is a very inflammatory condition that we often see in dermatology. This is an example of a squamous cell carcinoma of the lip in an African Canadian, or actually this patient was American gentleman. So that brings us to another case. A 42-year-old black man who presents to a dermatology with a 1-year history of discoloration of his toenail, who reports repeatedly injuring this right great toenail while playing soccer. It started to become painful, and he's wondering what options are available to fix this problem. So here's the case. I don't think anybody here would think that that was normal. What is the most likely diagnosis? So is this trauma induced from repeated hemorrhage? Is this a fungal infection potentially? Pigmented basal cell carcinoma, pigmented squamous cell carcinoma, acrolentigenous melanoma? Yeah, so that's definitely an example of a melanoma, which is the third most common type of skin cancer in all races and the most deadly form of skin cancer. The issue here with patients of color, although it's not extremely common in them, is that the 5-year survival rates of blacks and Hispanics are consistently lower than those of Caucasian patients. And there's a statistically significant increased risk of death for black patients with melanoma as compared to Caucasian. If you look at the worldwide incidence of melanoma and the mortality rates, you can see here that Australia and New Zealand have by far the highest incidence of melanoma. But if you look here for the mortality rate, which is the light blue bars, you see the Caribbean here. And you see they have the highest mortality rates. Most patients in the Caribbean are of color, and so that of course, is something that we need to discuss a little further. So risk factors for melanoma, traditionally we talk about fair skin, intense sun exposure, blistering sunburns, a personal or family history of skin cancer, multiple nevi, etc. The risk factors that are probably a little more important actually in persons of color were their scars, trauma, pre-existing pigmented lesions, some immunological and environmental factors. None of this has really been elucidated very well. Ultraviolet radiation is not a significant risk factor for the development of melanoma in patients of color. So 60 to 75% of melanomas in non-Caucasian patients will arise on the palms, soles, or subungual areas, aka that's otherwise known as acrolentigenous melanoma, and also on mucosal sites. The most common site for melanoma in Caucasian patients is in the back in males and the calves in females. So the clinical pearls for this case are that melanoma typically affects sun-protected sites in persons of color, especially the palm, soles, and mucosa, and that melanoma tends to present at a later stage, therefore is associated with more aggressive prognosis and more aggressive tumors and an increased mortality. Here are just some further examples of what melanoma might present like in your patients. This is on the bottom of an African American male's foot. And melanoma doesn't always have to be black or brown. Sometimes we have one that might even look like a pyogenic granuloma, for example, the so-called amelanotic melanoma. This was on a Hispanic gentleman. And this is another example of a melanoma of the foot in a Mexican gentleman. So that brings me to sort of the last three cases, and I'd like to sort of combine them together a little bit. Which of the following is most likely to represent a malignant process? So, A, anyone for A? B, okay, C, okay. So I was kind of unfair there because all three of these represent malignant processes, and I didn't give you the option of all of the above. The first case is a case of cutaneous T-cell lymphoma of the skin. Cutaneous T-cell lymphoma typically will present with these sort of eczema-like or psoriasis-like patches or plaques, usually in sort of sun-protected areas. Especially in Caucasian patients, it will present sort of like the photograph on the left. On the right-hand side, people of color will present often with these hypopigmented patches and macules of differing sizes, often on the trunk and extremities. And so I'm sure many people have seen patients that might look quite similar to this. There is a differential diagnosis. But if you see a patient who is of color and they have sort of progressive hypopigmented patches, you have to consider cutaneous T-cell lymphoma as a possible diagnosis. There are many types of cutaneous T-cell lymphomas, including mycosis fungoides. This is probably the one we talk about the most. And as I mentioned, hypopigmented patches is the most common presentation in people of color. You might consider something like vitiligo, although vitiligo tends to be much more depigmented. There's a condition called progressive macular hypomelanosis associated with Propionus bacterium acnes infection, cutaneous sarcoidosis, and there are other things on the differential. Black patients are thought to be 2 times more likely to be affected with mycosis fungoides or cutaneous T-cell lymphoma than Caucasian patients. The etiology is largely unknown, but there is another type of T-cell lymphoma called adult T-cell lymphoma leukemia. Originally, that was called Jamaican man disease. These patients present with this widespread skin eruption, and then they have some neurological issues as well, and that's been associated with the HTLV1 virus, which is endemic to the Caribbean, Japan, Sub-Saharan Africa, and South America. Cutaneous T-cell lymphomas tend to have a more aggressive course in Black patients, largely due to the delay in diagnosis. I'm not sure that I've seen this in my practice, but there was one study that I read that reported up to 44% mortality. In my practice, what I've seen is that CTCL tends to be much more of an indolent condition that you just follow over time. Early stage CTCL is usually very treatable. Treatment options include topical steroids, topical nitrogen mustard, phototherapy, electron beam therapy. Here's just another example of cutaneous T-cell lymphoma in a person of African descent. The next picture I'd shown you was of a dermatofibroma sarcoma protuberans, or a DFSP. This often is mistaken for a keloid. If you have a very unusual looking keloid on any patient, Caucasian or of color, you might want to consider this diagnosis. One study did find this tumor to be increased in Black patients, followed by Caucasians and then Asians. However, in the ethnic skin research clinic that we run at Women's College Hospital, and certainly in our MOS center, which is something that is usually used to treat these, we've actually seen this much more commonly in our Asian patients. I have actually not seen a DFSP in a Black patient. I've seen it in Asian and in Caucasian. So, it's a rare tumor, so I think studies potentially, that study it was just a very small sample size, so I wouldn't take that as a take-home point that it occurs most commonly in Blacks. All right, and we talked about melanoma already, but I really wanted to highlight this photograph in particular because this is another example of a melanoma. You see this sort of thick band of Black pigment, and I don't know if you can see it well on the screen, but there's a little bit of pigment that's kind of going right up onto the proximal nail fold. So we call that a positive Hutchinson sign, and it can be very subtle. If someone has a positive Hutchinson sign, that is something that you need to think about biopsying for the presence of a possible melanoma. Melanomas like this often develop after having sort of a pre-existing nevus or pigmentation on the nail. So what are the pearls with these cases? So when a patient of color presents with hypopigmented macules and patches, with or without a little bit of pruritus or itchiness, consider cutaneous T-cell lymphoma in your differential diagnosis. If someone comes in with an atypical looking keloid scar, consider the diagnosis of a dermatofibroma sarcoma protuberans, or DFSP. And if a relatively benign-looking nevus presents on the nail apparatus of any patient, check for pigment on the proximal nail fold or Hutchinson sign. So that brings me to the end of sort of what I wanted to talk to you about today. The take-home messages are that despite a lower incidence of skin cancer in people of color, these patients do have increased morbidity and mortality when compared to people of Caucasian descent, and so we do really need to promote patients looking at their skin, and we as physicians also need to look in especially sun-protected areas and things like that in these patients, and not just think that because they have that natural SPF that they're not going to be getting skin cancer. Ultraviolet radiation is not the primary cause of most skin cancers in people of color. Skin cancers are found in sun-protective sites, and the presentation of skin cancer in persons of color can look vastly different than in Caucasian patients. So, for example, in the pigmented basal cell carcinomas and in cutaneous T-cell lymphomas. So I'd like to thank you for your attention, and I welcome any questions. Oh, sure. Hi.
Just in general with skin cancer prevention, not necessarily to blacks or non-Caucasians, can you comment on Helioplex or any of those oral supplements I've heard about that you can try to decrease your risk of?
Sorry, could you repeat the question?
There's over-the-counter supplement that I heard of called Helioplex or something like that you can take. Can you comment on that, not necessarily for non-Caucasians, but just in general for skin cancer prevention?
Sure. So the question was about Helioplex and skin cancer prevention. So Helioplex is it's a component of sunscreens, and so I think that's what you're referring to, right? So. Oh, HelioCare. Oh, I thought you said Helioplex. I apologize. I'm not familiar with HelioCare. I don't know if any else from our faculty is, yeah.
So HelioCare is a tropical fern extract. It's called polypodium bucatomus, and we did a lot of research at it on University of Miami. That's why I know a little bit about it. And it inhibits sunburn cells and DNA damage after UVB radiation in multiple clinical trials. And I did a clinical trial with HelioCare for melasma, and in a blinded, double-blinded trial, the patients with melasma on HelioCare had their melasma decreased. So it is an oral photoprotectant, and I think it's similar to any antioxidant like green tea or anything that you can take orally. There are multiple things that have been shown to reduce the effects of the sun, and I think it's really because it's an antioxidant, but the most studies have been done on this polypodium, so you can recommend it to patients. I use it in patients with melasma, with polymorphous light eruption, and then I don't have a large skin cancer population, but it is reasonable if they are concerned or photoaging, they can take it as once a day, and if they're going to get a lot of sun, they can take 2 pills instead of 1. It's in the supplement. It's taken every morning, and then you can take a second dose if you're having more sun exposure than normal. For example, if a patient plays tennis, she'll take it again at lunchtime. Or people who are very sensitive to sun, you see this in Canada all the time, they go on vacation, get a rash, they can take it when they're on their cruise, the Caribbean cruise, because those people who are ultra sensitive to sun, it helps to protect them. It doesn't replace sunscreen, but it helps to protect them.
Thank you so much, Dr. Woolery Lloyd. Sure. Mm-hmm. Mm-hmm.
Dr. Viculagan, they want you at the mic. Dr. Viculagan, they would like you at the microphone.
Okay. I could repeat for him. But.
Just oral cancer at the East Indian mainly is usually it used to be betel neve and betel nut that you chew a lot of it.
Right.
Is that common here?
So it's definitely been reported. It's not something that I have seen at the Ethnic Skin Research Unit. We have seen patients with oral cancer, but typically it's, smoking or tobacco use, but certainly that's definitely been reported.
The second thing is, it used to be said, beware of the man with the glass eye and the large liver. Where do these metastatic lesions, especially in the ethnics and the blacks, where do they metastasize from, say, the feet or the...
So melanomas, so you mean melanomas in terms of where do they
Yeah.
metastasize? Sure, so melanomas, especially thick melanomas, can metastasize often first to the lung, unless it's ocular melanoma, which tends to, for some reason, metastasize first to the liver. They'll metastasize to the lung, to the brain. You can get bony metastases. So, I mean, they can cause a lot of metastases throughout several organs in the body. Is that answering your question, or?
Okay. And the last one is, the new thing now that they're using these immune suppressants, such as the new biological modifiers, say like Humira. I just have a patient, it's only 22, treated for Crohn's, now he's got lymphoma. Is this going to be the new thing for the future, that we have to keep an eye on people on the new medication?
So definitely an interesting question. So patients using biologics for things like psoriasis, Crohn's, et cetera, there have been a few studies that have suggested there might be a slight increase in non-melanoma skin cancers. Definitely, if someone has been diagnosed with a melanoma, we will not typically put someone on a medication like that. But basically, what is recommended that we do, like we do with all of our other patients, which is just to do a full skin examination for these patients when they come in, looking for anything like that. But really, the numbers are extremely small.
Thank you.
No problem.
Great presentation, by the way. I was just wondering, do you prefer chemical sunblocks or physical sunblocks? And there's some controversy over oxybenzone and I think it's retinol palmitate in sunblocks, and I was wondering if you can comment on those.
Sure. So I think both chemical and physical sunblocks are appropriate for patients. I think it's person dependent, though. So a lot of the physical blockers will cause sort of a discoloration that people aren't comfortable with cosmetically and things like that. And so a chemical sunscreen might be something that's more appropriate. Really, what I tell my patients is they just need to make sure that they're protecting their skin as much as possible. So a minimum SPF 30, giving them 97% protection. And actually, I even recommend higher than that in all patients. I recommend, black patients, darker skin patients to use sunscreen every day, mainly because of the dyschromias that they tend to get. But, I also recommend higher than 30 now, because there were studies showing that patients don't apply enough sunscreen when they just use the SPF 30. And so they're actually getting about an SPF of 15. And so I recommend, whichever the person is most comfortable with, I typically will recommend. And certainly in children, I usually will recommend more physical blockers over sunscreens.
Thank you.
For any of this, we do require a biopsy. So can you recommend how deep should we go? And if so, what about the scar that is left after we do the biopsy? Does it heal?
So great question. So any person that you're suspecting cutaneous malignancy, it will definitely need a biopsy. Some of the photographs I showed you were quite striking, and so typically for a melanoma, for example, we try to excise the entire thing and do something called an excisional biopsy. That's not necessarily practical in certain cases. If there's a melanoma on the face, for example, or you're thinking of a melanoma on the face, you might want to do something called you might want to do sort of just a few biopsies of many different areas, especially if it's quite large, to try to get an idea if that's a melanoma. The one I showed you on the foot, that would be quite difficult to excise yourself in clinic, and so you definitely want to go deep. You don't want to do a shave biopsy on these lesions. You want to go deep to the bottom, ideally to fat, in order to sort of, because the prognosis of melanoma is based on depth. So you really want to go to fat if you can. In terms of squamous cells or other things, it really depends on the particular lesion. So the one I showed you of the squamous cell in the hidradenitis suppurativa, you can't possibly excise all of that. So you might want to take a few sampling biopsies. Just take the part that looks most atypical to you.
A melanotic melanoma, is it an issue, skin color, and how frequent it is?
Sorry?
Amelanotic.
Amelanotic melanoma?
Melanoma.
So that's, I'll briefly answer. That's a very interesting question. A lot of patients, so like patients with oculocutaneous albinism are probably at highest risk in terms of sort of people of color, quote unquote, to develop amelanotic melanoma, but certainly anyone can develop an amelanotic melanoma. But patients with there's been patients with cutaneous albinism are typically the ones who are going to develop an amelanotic melanoma in terms of our quote-unquote skin of color patients, although technically some might argue they aren't of color, but biologically they are.
Thank you very much, Dr. Yvette Miller-Monthrop, for your shared clinical pearls on different skin cancers, basal, squamous, melanomas, cutaneous T cells, and of course your call to arms for us to be vigilant in terms of screening and health promotion. Our last presenter before lunch is Dr. Ron Venter, who is a dermatologist from Hamilton, Ontario. He's the founder and CEO of Dermatrials Research Incorporated and functioned as a principal investigator for more than 80 clinical trials. He's an associate clinical professor of medicine at McMaster University and the Department of Medicine, Division of Dermatology, and of course been well recognized and well published in many, many different journals, serving, for example, in the editorial board of Journal of Cutaneous Medicine and Surgery, as well as the Journal of Clinical and Experimental Dermatology. He's been recognized internationally for his work in the field, particularly in the areas of psoriasis and psoriatic arthritis management. He'll be speaking to us on the topic of systemic therapies for acne in skin of color, what's new? Dr. Ron Venter.
What kind of music's that? Okay. You've heard this before. I'm the guy standing between you and lunch. So if I look like a big piece of chicken standing up here, then so be it. All right, thank you very much, and thanks for having me here. We have a timer on here. It says 21 minutes and 56 seconds left. So we'll go. Remember, this is a systemic treatments for acne patients. And okay, what's new? These are my disclosures that I'm supposed to state as well, and some conflicts of interest. Basically, I don't get anything from anybody. I'm just here. And I don't really have any mitigating potential bias, whatever the heck that means. Mitigating potential bias. Am I mitigating? Carrying on. All right. So Dr. Raman, who's speaking this afternoon, looked at me and says, how come you're speaking at a Skin of Color conference? And I looked at myself and I said, I don't know. But I'm here anyway, I guess because I'm the lighter shade of skin of color, white, I guess, something like that, which is okay. So I work in Hamilton. I don't do any cosmetic dermatology. I do specialize in psoriasis, but I see acne, warts, dermatitis, skin cancers as well. And that was a great talk on the malignancy as well, Yvette. Our patients that we have that with skin of color that have acne are certainly have a big psychosocial disturbance with their skin, let alone that they have acne, that they have discoloration from it. And everybody likes to have nice and smooth texture and tone to their skin, but these patients that have acne with skin of color have noticeably a lot of inflammation. And this theory as to this non-inflammatory and inflammatory type of lesions that have occurred of comedonal and then inflammatory lesions has sort of fallen through a little bit. And it was probably first described in those patients that have darker skin, where